A very wise friend of mine, Tom Steinberg, once said, without ritual and bureaucracy, there would be no University of Oxford. There would just be one bloke who was really good at writing theology essays in 1286. And it's absolutely true. What I'm going to talk about today is how to move beyond single research outputs from single individuals, how to build systems and structures and platforms that drive better, broader, safer use of data. I've been instructed tacitly that you have to give some kind of account of where you come from. So principally, I'm going to be talking about 3 tools that we've built: OpenPrescribing, TrialsTracker, and OpenSAFELY. But first, I guess I should mention in passing bad science. Some of you might wonder, why is a Guardian columnist being appointed Professor of Evidence-Based Medicine at the University of Oxford? I should say, I went to medical school here 800 million years ago, and then did psychiatry at the Maudsley and epidemiology, applied medical statistics at London School of Hygiene and Tropical Medicine. And then I came back here in 2015 to set up the Data Lab, now the Bennett Institute. Bad science along the way was a hobby, but it was a great fun hobby. And I must say, in 10 years of writing a weekly column debunking bad behavior, a couple of things come to light. Firstly, I should say, I was always very much a generous and inclusive debunker. It wasn't just quacks and bad behavior by journalists, it was also misuse of science by academics, by politicians, by government, and so on. And secondly, it wasn't about dividing all the utterances in the world into the ones that are either true or false. It was a gimmick. It was an opportunity to talk about research methods to the widest possible audience, to talk about how you do an analysis correctly, attempting to engage the audience with a little bit of moron bashing to make it somewhat more palatable and exciting. Now, there's one thing that happens when you start picking through large volumes of research from a huge number of different areas, which is it gives you a kind of bird's eye view. And it gradually became clear to me that there are all kinds of deep structural problems in the way that we do science that weren't being adequately addressed, and in particular, weren't being adequately addressed by people producing ever more single individual research papers. Now, somebody said that you have to have this sort of articulating story of why you do what you do. If I'm honest, it comes down to this. To use the tools of epidemiology for public good by any means other than publishing yet another academic paper. And more broadly, to use the tools of epidemiology for public good by using data to build machines that can act in the world. So what do I mean by that? Well, I was very inspired by the early work in particular of My Society. So My Society was an extraordinary outfit set up to use data and software engineering for public good. You can see how long they've been around because look, their first project was Fax Your MP back in the late 90s. And what they articulated and then most importantly shipped on was this vision that you could scrape and extract large volumes of data, and then instead of turning them into a paper or one report by you, you could instead turn them into a live, practical service driven by the data that could go out and act in the world. And my first experience of doing this myself was with my friend John King, who's somewhere around here, and we were sat on my boat near Tower Bridge, where I was living at the time, and I had this sort of obsessive period in 2008 when my book first came out where I would refresh my Amazon page ranking about once every 10 minutes. And I knew this was unhealthy. And John and I sat down and he said, well, how about if you use grep, which is a really terrible way to do this, any software developer will tell you, how about if we grep, then we can scrape it off the page and then we can just take your page ranking and then just add it to a file and then you can graph it and you won't have to look every 10 minutes. You can just look maybe once an hour or even graph it and look at trends. And there's a moment when you do that for the first time, when you meet one of your own needs with a few lines of code, where you look down and you genuinely think, with hands like this, we could, dare I say it, rule the world. So, that is what we set out to do. Ultimately, we became the Bennett Institute for Applied Data Science. And we are different to other research groups in 3 important ways. Firstly, We're not just interested in producing research papers. Of course we do, we have to keep the institution happy. We ship papers in Lancet, Nature, BMJ, and all the rest. But crucially, we also do practical data science for the NHS, looking at opportunities to improve the quality, safety, and cost effectiveness of care. Because, dear God, the best way in this brief time on the planet that you can reduce suffering and death in society is not by inventing another drug or publishing a paper or producing even a single static dashboard. It's by optimizing the logistics of the delivery of care. Watch me make that sexy. Secondly, we make our own papers and reports, but we also build data infrastructure, tools and services for the whole community to use beyond ourselves. And then lastly, because we do more than just build our own papers, because we do more than just do research, we employ more than just researchers. We hire software developers, because if you're going to write a line of code, it makes sense to employ people who have been writing code for 2 decades. We employ policy wonks when we want to understand where the system is going wrong and the right way to nudge it. So. We started off pretty small, then we looked like this, then we looked like this, then we looked like that, and then we look like this. That's Christmas in July during COVID. And then we look like this. Look, we've even got faceless babies. We protect privacy at all costs. So, first up, I'm going to show you OpenPrescribing. Or rather, how we built a machine to replace error-laden, time-consuming manual labor in Excel mines for less than the cost of one tiny analytics team. So when we first came at this problem, there was an enormous amount of prescribing data out there. In fact, the prescribing data that drives OpenPrescribing had sat in the open on the public internet as an open data set since October 2009 without anybody really doing anything with it at all. And the way that people would work with prescribing data was essentially, oh, we'll download it, Barbara will do you a cut, and then if you copy and paste that onto this tab of this Excel spreadsheet that some guy in Southampton made, that'll do a pivot table and maybe a graph, and it was error-laden, it was slow, painful manual labor that was likely to not just produce incorrect answers, but also the cost per graph, the cost per analysis was huge, and we thought we could do better. So what we built was a service, a tool called OpenPrescribing. OpenPrescribing today has over 25,000 unique visitors per month. It's probably the single most commonly accessed data analytics tool for NHS data. And the graphs look a little bit like this. So, for example, so you can understand this, usually when I do this, everyone goes, woo, because it's such an exotic pointer. Okay, so thanks. It means a lot to me to hear you do that. Okay, so if we look at this one, you can see this is data over the course of 5 years. This is an ancient slide. The data on OpenPrescribing is current and up to date. And you can see over the course of 5 years, the blue dashed line is the national average for this particular prescribing measure. The dotted lines either side are the decile lines. So the highest one is the top 10% of practices. The bottom line is the bottom 10% of practices. And then the red line is the performance of this individual CCG, NHS Rushcliffe. Remember CCGs? The NHS has to re-disorganize itself every 5 minutes. Now, this is an old static slide. And the measure here, all of our measures, it's always, if you're high, you're generally bad or room to improve. If you're low, you're good. And you can see on this measure here, this is over time when a very commonly prescribed oral contraceptive pill called Cerazette became available generically as desogestrel. People should have gone away from expensive Cerazette high down to good, cheap desogestrel. So you can see NHS Rushcliffe, they changed early in a really good, coordinated, sudden way. That's people going out and going, all right, everyone, we've got to stop prescribing needlessly expensive Cerazette. You can see here, Nottingham, same thing. You can see in Swindon, sort of gradual change over time. This is the pathology of the medical, this is the dissemination of knowledge through the oral tradition of the medical profession. Barbara, have you noticed that everybody else seems to be, gosh, bloody hell, okay, well, let's, yeah. And then over here, Lincolnshire and West Norfolk never quite got the memo. But the point is not to produce these static tables. OpenPrescribing is a live, interactive, data-driven service where anyone can go. You can type in the name of your own practice and it will find it instantly, whether you're a doctor or a patient or a policymaker or a journalist or a researcher, like the many researchers who've taken our data from our tools and services to do their own research. And to demonstrate this, do I have a volunteer who's a GP? Look, no, it's too mean. And also it's being filmed. I have arbitrarily selected, just so you can see how it works and believe how it works, but please go home and do it. OpenPrescribing.net, type in your own GP. So what you get, this just happens to be, this is arbitrary, this is the closest GP practice to this room. And when you get there, you get a page of, you can see some standard prescribing measures. We've got some ready-baked measures for you, looking at safety, quality, and cost-effectiveness of care. Keith Ridge's team, when he was chief pharmacist at NHS England, they made essentially a do not prescribe list, but you mustn't call it the do not prescribe list, but it's the do not prescribe list. So we have live data. We had that up within about 4 days of the do not prescribe list being available, with data for every single individual practice in the country showing how much they were prescribing of that, so that people can look at it and go, I didn't know, thank you, I'll change. And then lots of our more elaborate data science stuff down the bottom. So for example, this is from the NHS England do not prescribe list. You can see they're prescribing an awful lot of liothyronine. And most people, I think, would say, do you really need to use liothyronine? It might be better to use levothyroxine, and you'd have saved about $5 grand over the past 6 months. And this is helpful, useful feedback. Now, to be absolutely clear, this doesn't mean that it's a bad practice. There might be perfectly good reasons why they're prescribing the more expensive option. It also may be an oversight. People often come to us and say, oh, so what's the worst practice? And actually, it's a sort of personal failing. I spent ages going, oh, we've got to find clusters. Maybe there are doctors or practices who tend to be really bad at safety or really not attentive to cost effectiveness. And we never found any patterns in the data. And eventually, I realized this is actually something brilliant, because essentially, all doctors are basically pretty good at everything. But almost every practice has a few things that they've overlooked. And the beautiful thing about that is, if you tell them, they'll probably change. So, next, here are a couple of the more interesting safety and quality ones, because it's not just about cost. So up at the top, what's this? Oh yeah, so they're quite bad at using, you shouldn't really use COX-2 inhibitors for pain. They've got side effects and heart attack and all that sort of thing. There may be good reasons. And then next up, oh, interesting. So the NHS, the novel anticoagulant drugs, the NHS bulk bought edoxaban. And NICE said, look, everyone should probably just use edoxaban, and we've got a job lot, so could you all use edoxaban, please? So you can see over time, this only happened in the last few months, so over time, people have gradually just started changing, and this practice hasn't yet noticed, and they will, and it will plummet. So we've also got other clever things that tell you about when things are out of stock and the price goes up, bit of a problem since Brexit, and clever ways of spotting the biggest cost-saving opportunities in your practice and all of that. Now, alongside this beautiful data science tool, we've also produced a metric ton of papers just to keep the ref people happy. Gotta feed the ref. Let me show you some of the stuff we do. So one major category for us is trends and variation, changes over time in prescribing. So here you can see changes in opioid prescribing over the course of 20 years. And this is a beautiful illustration of how when we have an idea, we don't just ship a paper, we don't just ship a tool. We get multiple outputs from the same bit of work. So this was led by Helen Curtis, who's right there. And you can see we did the paper in Lancet Psychiatry. That's a good address. We did the metric on the OpenPrescribing site, and we shared all of our code. We'll talk later about why that's important. And here's a nice, very generous editorial in Lancet Psychiatry saying, OpenPrescribing is a beautiful thing. Without a login, you can just go in and play. You can see the data for yourself. You can find the patterns that matter to you rather than the ones that we choose to put in our single research papers. So, what else? We've done studies on what changes clinical practice. So, when the chief medical officer says, can we all stop hosing antibiotics out at our patients, please? Does it make a difference? And the answer is, yeah, kind of a little bit, just sort of. When NICE says, can we offer tamoxifen to about 8 times as many women, please, to prevent breast cancer? Does it change practice? The answer is, yeah, kind of, a little bit. Most things in medicine that you try don't work. Most things that do work only work a little bit. That's not a counsel of despair. Radical incrementalism. If you can lower the cost of discovering each signal, if you can lower the cost of delivering each intervention, especially if it's a knowledge intervention, then you can change practice at scale. Next. So this is a beautiful one where, oh yeah, we did a study to see if whether people who, practices whose data is looked at a lot on OpenPrescribing go on to have better prescribing. And the answer is, reassuringly, yes. And just to make sure you don't think we cherry-picked the answer, we published all our code before we ran the analysis, before we even looked at the data. What else? We've done randomized trials, super low-cost randomized trials of knowledge interventions. So we did a trial of sending out graphs to practices to see if that reduced reduced their antibiotic use? And the answer is yes, it does, a little bit. Keith Ridge, who was previously chief pharmacist. We've got the ex-chief pharmacist and David Webb, the current chief pharmacist here from NHS England. Keith Ridge, when the do not prescribe list, that you're not allowed to call the do not prescribe list, was published, he said that he was going to go out and talk to the 20 worst performing CCGs, or the highest users of the things on the do not prescribe list. And we said, wait, don't do that. Why don't you give us the worst 40, and then we'll randomize the people who get a visit from the office of the chief pharmacist, and we did a randomized trial of Keith for incredibly low cost. So, what else? Once you've got all the data in one beautiful data frame, you can start thinking about interesting and creative ways to interrogate it. So, for example, there is a natural structure endogenous to the prescribing data, endogenous to medicines, which is that every drug is a member of a class of drugs. So, one antibiotic is a member of the class of antibiotics. One antipsychotic drug is a member of the class of antipsychotics. So we started thinking, well, how could we interrogate the data in a way where, let's say, for example, if we just want to filter for interestingness, is there a way that we could approach the data where we could say, show me the drugs where there is the most disagreement between doctors about which is the best drug to use in that class? Now, if you want to do that, you maybe think, okay, if I was doing it by hand, I'd do a scatter plot. I'd say volume of all drugs in that class, and then volume of one drug in that class. And I'd be interested in how spready the data is. And there's a coefficient for spreadiness, kind of. It's kurtosis. So if you instruct the computer, not a impoverished PhD student having a miserable life in the Excel mines, if you instruct the computer and say, okay, in your head, don't show me, can you just do a scatter plot of every drug within its class, measure how spready they are with kurtosis, give me a ranked list, and then in that ranked list, at the very top, I should have the drugs where there is the most disagreement among doctors about which is the best drug in that class to use. And when you do that and you start looking at the data, and God, it took forever to get this paper published because people don't understand what this is. They want you to crank the handle. Oh, explanatory variables for an outcome. Here we go, logistic regression. So, for example, Paracyanine is an antipsychotic drug, which I'd literally never heard of, for good reason. It's got about 83 papers ever published on it in PubMed, whereas risperidone, olanzapine, antipsychotic drugs you've actually heard of, have got, I think, 8,000 and 16,000 publications apiece. Paracyanine is not used anywhere in the NHS, except in one CCG, where it made up, at the time that we first spotted the pattern, about 1 in 5 of all antipsychotic prescriptions. And where is it? It's Norfolk. There they are. Look, there you go. You can find it automatically on the site. Next. What else? So a genius called Brian McKenna, who's a pharmacist, was seconded to our team from the office of the chief pharmacist for 6 weeks to learn how to write a line of code and work on prescribing data. Now, the beautiful thing is he had deep domain knowledge, but he'd never really touched a computer before in this way. That was 2017. We've not yet given him back. And he started with his deep domain knowledge going, I'm just going to muck around, I'm just going to have a look and a think and a tinker. And one of the things he looked at was, he said, I wonder, are there any drugs where the tendency to prescribe them, or any prescribing behaviors where the tendency seems to cleave along the lines of which electronic health record system supplier is providing the software to the practice? Because there will inherently be interesting, possibly, differences in how you're presented with a picking list. And the answer was yes. Look at this. So in one electronic health record system, there's this huge thing which was losing the NHS about £11 million a year. We spotted it, we tweeted at the vendor. They immediately wrote back and said, oh, that's very good. They're now very good friends. They were literally at their Christmas party in the pub. And they emailed back, and within a few weeks, they had pushed a fix. And after they pushed the fix, this trend basically continues. You can see the excess cost to the NHS absolutely dropped off a cliff. With another software supplier, we found not a cost signal, but a safe prescribing choice, where it was much more prevalent just in one supplier. Now, this is fascinating, beautiful window into not just the data, but also the whole business of informatics, of how doctors interact with machines that store knowledge about their patients. And also, by the way, for anyone who's a software developer, what a beautiful window into this, because if you ship Microsoft Word, you don't get to see every document produced by your word processor, but actually in the prescribing data, in the medical data, It's an extraordinary thing. You actually have the complete data of everyone who's ever used your service. This is a magical and beautiful mine that we are digging in today. So, you get all these interesting patterns. You get interesting patterns, of course, over time. So we wanted to start exploiting the dimension of time. We wanted to start thinking, how can we spot interesting patterns in particular? We want to know, for certain prescribing behaviors, it would be interesting for some of our research to know just which practices change early and which practices change late. And also, when they change, do they change in a sudden dramatic way, like Nottingham and North and East CCG? Or do they change very gradually, like Neen CCG? Because this is obviously a single-minded, concerted act by a medicines optimization team, whereas this is people going, Martin, can we stop doing that, please? So, what can you do? Well, we looked at the change detection stuff in finance data. It doesn't work because finance data is sort of every microsecond. But climate data, climate modeling code rather, actually very good. So mate of ours, Felix Prettis, who I met when I was a fellow at Nuffield. This is the joy of Oxford. You see, just throw people in. He had produced this lovely R library, which he had shared as open code for detecting change in time series data. We took it, we adapted it, we played around with it, and we managed to find a way of fairly confidently detecting when people changed. Is it a sudden drop? When did it happen? In what year? How fast? How coordinated? Or over here, it's a slow, gradual change, and it started about a year later. So with this, you can then start to do projects like this BMJ paper, which is, by a country mile, the largest study ever done on the diffusion of innovation in the NHS. This paper here shows you, so this histogram up at the top, this is basically showing you in each month there was a warranted change in practice. It was to stop using trimethoprim for uncomplicated urinary tract infection, one of the most common presentations in GP land, if not the most common, cystitis, for want of a better word. And the instruction from Public Health England in about 2014 was, dear doctors, please can we stop using trimethoprim, and in general, we'd prefer you to use nitrofurantoin if there's not a good reason to do otherwise. So we said, well, let's have a look. Each month, let's do a nice histogram, having sucked out of the date on which people changed their practice, and let's see if we can have a histogram showing when people change. And look, you can see when Public Health England said, please can you all change, about 3 times in a row, nobody really paid any attention. Then NHS England said, oh, fine, we'll pay you. And then everybody starts changing. And the top line you can see when they changed, and the bottom line you can see how coordinated it was. So look, in that bottom thing, you can see that when there was a pay thing on that thing, they went, okay, it's not going to be a gradual decline, it's going to be wallop. Here we go. Now, the other beautiful thing you can do with this is you can use it as a kind of improvement radar, which we're now discussing with NHS England. So, for example, it's an opportunity, because this isn't about naming and shaming, this is about helpful practical feedback. You can find the practices that have embodied, in any given local area, a positive change early and in a nice coordinated way. So we did a paper on statins. So there was a big new, nice guidance that said, okay, statins, low potency statins, probably shouldn't use them anymore because high and medium potency statins are just same cost, same side effect burden, but much more effective at preventing cardiac events. So please can you all use moderate and high intensity statins? And so we did a paper showing that there's very gradual adoption of this, and a few GPs said, well, that's not very fair, because it's actually really hard to change all your statin patients at once. And we said, well, we hear you, but actually, let's just quickly run our code and say, look, there are loads of practices that did it overnight. Click, click, click. If you can spot the practices that embody good practice, then that's something for others to learn from. So next, we're doing the opioid improvement radar. Find the local practices that have done the thing that you want them to do. Next! So, we don't just do this for our own interest. We also produce integrated tools and services. We build this complex data science into a simple platform. So what does that look like? Well, change detection. I thought in 2015-16, I thought we don't just want the data to sit there. We want it to live. We want it to act in the world. We want a way for the data to be able to step out, tap you on the shoulder and say, hey, by the way, you've got a problem. So what I wanted was a way to tell practices, not just that they were in the worst 10% for a given prescribing behavior, but rather to be able to tell them early when their behavior began to deteriorate in comparison to their peers. So this is the one that we saw earlier of Cerazette versus desogestrel. It's a cost-saving measure, but the same for safety and for quality measures. And you can see up here, this red line as it drifts along, they're already doing pretty good to start with, but then when it comes to about 2014, 2013, all around them, The medical profession is changing. Everybody's moving from Cerazette down to desogestrel. But they didn't get the memo. They didn't notice. Now, if I'd waited until they were at the worst 10% before I sent them the measure, we'd have wasted 2 years, God knows how much money. Well, we calculated how much money. And we'd rather send them a message early. Now, if you want to send them a message early, you've got to do all kinds of clever stuff. You want to detect when they're changing over time. Now, there are clever ways of doing this, and there are other things that people have done in the past, so we adapted those. Cumulative sum is a nice way of doing it. And so Alex Walker, who's around here somewhere, he's right there. So he wrote in Stata, oh, naughty, old-fashioned commercial proprietary software environment. He wrote in Stata, implemented the ideas that we discussed around cumulative sum to detect when people change. So that was brilliant. That was enough for a paper. And I said, well, that's great. So you remember how we talked at the interview about how you'd have to learn Python? Now is the big moment. So go and re-implement this in Python. And that's exactly what Alex did. And then something beautiful happens. Because Alex's code, which in the traditional academic model and in the constrained bottle of working in Stata, that would have been the end of it. You make one paper, you make one set of dashboards, you put it in a PDF, it sits and dies on the internet, and nobody cares. But instead, because he wrote it in Python, his code that every week runs against, every month runs against the data as it updates, his code that Alex wrote just sat on his sofa, one human, once, 7 years ago, every month when the data updates, it filters through, it looks for the changes, and it sends an email. It acts in the world. It does something. And we now have 5,000 subscribers to this service who get emails every month telling them the things that they're not doing very well on. So this data sat unused on the internet for 1 billion years before we came along. And that shows you that data doesn't know what it's good for, and data doesn't do good work on its own. What's next? I will never tell you. You should be very suspicious in the world of data infrastructure and data platforms of people with PowerPoint slide decks about what they plan to build. If they can't show you a prototype, get in the sea. So, next. Right. Clinical trials transparency. So there's this problem in the world of clinical trials. The trials which are conducted and completed routinely go unreported. Now, this was well known, well documented throughout the medical literature for many years. In fact, first paper is probably 1980, then 1986, Symes wrote a paper saying, can we just register our trials? At least then we've got an audit trail of which ones have and haven't been done. Now, I wrote about this in The Guardian in the late 2000s, and then I wrote about it a lot in my book. And the message that comes back from pharma in particular, academics stayed silent, and this is interesting for later. The message that came back from pharma was, this has all been fixed. There's long documented and historical long address. This is all fine. Don't worry about any of this. It's all fine. And we knew it wasn't. So we thought we have to act. We will write a letter to the Times. Obviously, this achieves nothing. So then we said, no, we're going to go and meet Earl Howe, the minister responsible for this stuff. So, by the way, that's Sarah Wollaston, amazing MP and GP. That's Fee Godley, editor of the BMJ. That's me. That's Ian Chalmers, who's right over there, founder of the Cochrane Collaboration. That's Carl, who's down at the back somewhere. And we went to visit him, and we thought, this just isn't going to go anywhere. So instead, we decided we were going to set up a campaign. Now, a campaign is a specific piece of work. We don't think we know how to run a campaign. I can write a line of code very badly. Nobody should be permitted to use my code. So instead, am I allowed to take my gown off? Is that acceptable? Will you take my professorship away? So, we didn't run the campaign on our own. We got Tracy Brown and Sense About Science, professional campaigners who we knew from their track record of doing extraordinary stuff on addressing libel laws in science, on getting evidence-based practice, on training MPs in better use of evidence and data. So we said, look, could you help? Could we do this thing together? So, yeah, that'd be great. We do have to sort of pay mouths, and so my friend Simon Singh, who's sold 1 bazillion books and is up at the back there, Fermat's last theorem and all that, he's got a BAFTA, don't you know? Simon Singh said, look, I'll chip in to cover some salary time for a few months for somebody to work on it. And so we set up this campaign. And we asked for 3 things. We basically said, we expect every trial to be registered, every trial to be reported, and clinical study reports, detailed documents about methods and results, to be shared where they've already been created. Now, the first thing that happened was Stephen Whitehead from the UK Pharma Industry Lobby Group, who volunteered to be the pantomime baddie, rather unhelpfully. He said, oh, we will not respond to PR-driven initiatives such as AllTrials. That was in February 2013. In November, up against me on Newsnight, he said, I've never said that. Now, what is it that made Stephen Whitehead change his mind? Collective civic action. The entirety, or a very substantial part of the great and the good, signed up to the AllTrials campaign. Patient groups, funders, ICWIG, the German equivalent of NICE, literally the German government's cost-effectiveness agency. And why wouldn't they? Of course, because they need to look at this data to understand the risks and benefits and costs of treatments. Funders like Wellcome and also GSK, for example, global pharmaceutical company, said, do you know what? Yes, absolutely, yes. And furthermore, they didn't say yes lightly. I went to the Strange Members Club with Andrew Whitty, who's the chief executive of GSK, and it was not an easy conversation. They didn't go, yeah, fine, we'll stick out a press release. They said, all right, but what exactly do you want? And what exactly does this mean? And where are the bear traps? And we're going to think about how much this costs. And they signed up thoughtfully and deliberately, and it was the beginning of a beautiful deluge. So a long campaign ensued. And sometimes when you do this, people sort of invite you to feel like an outsider, which I've always found baffling, right? You're giving the system the help it needs, doesn't necessarily want. It should be an okay thing to talk about. If anything, we're kind of radically conservative. We should put the gown back on to emphasize it. But here was the problem as it stood. We realized the problem here was people were making big promises, they were giving false reassurance, but there was no monitoring of compliance, no consequences for transgression. And furthermore, for us, this was a setting with low or no resources, and lots of academic papers published on how bad this was that hadn't really achieved very much. So we thought, we're sort of simple-minded people, really. We're all doctors. You know, well, what about the quality improvement cycle? You just do an audit. You define best practice, measure it, give individual units the most informative, actionable feedback you can, and then you hope that somebody does something because you haven't got the resources to do it, and then you repeat the cycle critically. You don't publish one paper. You have live data that updates so that the incentives are, if you want to look better, if you want to survive a bad news story on this, don't rubbish the analysis, don't rubbish the tool, just report your trials. So, the TrialsTracker program, a beautiful thing. Again, not just a paper and a tool. So this is the EU Trials Tracker at eu.trialstracker.net. You can go there right now on your phone. There's a paper in the BMJ saying, oh, we've done this, and look, this is the proportion. And actually, interestingly, by the way, the two biggest predictors of people correctly reporting their trials in compliance with EU rules are, number one, you're an outfit that's done a lot of trials, and number two, you're a drug company. Drug companies had wised up. They had gone, all right, forget this. It's not going to cost that much. Let's just publish our results. So we produced this tool. And the beautiful thing about this tool is, first of all, it ranks on the front page the performance by each individual institution, each drug company, each hospital, each university. But also, it gives actionable information. If you click on one organization's page, you see all the individual trials, and you can see which ones are overdue. Now, when you launch a tool like this, and we did the same for American trials, this one updated literally every day. So as trials went overdue, they appeared on the front page the day they breached. Now, when you build things like this, first of all, you get massive reach and impact, in particular because you haven't done one study by hand that produces one static table summarizing the data. You've provided a tool where people can interact with it themselves. So in Canada, CBC News and lots of other Canadian news outlets go, okay, great, let's rank all the Canadian research outfits to see how well they're doing. In France, you get the same. In America, you get the same. In England, you get the same. People use the data in their own way with the tools and services that you have built. You encode the legislation in Python, as Nick DeVito did, and it was painful and hard, and then the machine goes off and it lives and acts. It has this almost autonomous life. Is that too romantic? In the world, driving people's behavior with the data. We gave it a few helping hands. The BMJ very generously took a rather delicious series from us called Unreported Clinical Trial of the Week, where we looked at all the trials that hadn't been reported, we picked out the most interesting ones, and then we would describe the background, the introduction. We'd say, look, this is the Cochrane review said, this is the biggest, most important clinical uncertainty in this field. And the great thing is when you look at trial registry entries, people are always bigging up their trial when they're starting out. So they write this for you. They really play up the relevance of their trial. And then you describe the methods. You say, this is exactly what happened. And then when you get to the results section, you say, sorry, this trial hasn't been reported. The email address of the person who has the results is just here. So this was not only a useful and I think interesting service, but also, look, you can't quite see it's hiding, but look, most read unreported clinical trial of the week. It was a smash hit. The people are really interested in unreported trials. And some of these were big and important. Pain relief after wisdom tooth extraction. Who's had a wisdom tooth extracted? Did it hurt? Yes. Would you like better evidence on how much it hurt? It was a massive, massive trial. So the needle began to shift. And suddenly you find, instead of being rubbished, European Medicines Agency, head of compliance, is putting out press releases saying, yeah, actually, this is pretty helpful, thanks. We got user feedback, and we got people from institutions saying, actually, thanks for letting me know, and it's really helpful that this is really granular data. It's accurate, I've checked it, but also, this is news I can use. People started using it to spot the trials which were about to breach, so that they could get in before their data breached. So the next interesting thing that happened was industry got its house in order, but academia did not, especially around Europe, with one critical exception of which I think we should all be more proud. So, House of Commons Science and Tech Select Committee did their third report into clinical trials transparency. They said, this is really bad. And not only is this bad, this is our third SciTech Select Committee on this. And select committees, in case you don't know, are a beautiful thing in government because they're one of the places where MPs do what you really want them to do. They get stuck in details. And they said, okay, we're putting out our report saying this is bad, but we're also going to have a follow-up session, which they very rarely do, and they should do it more because it's a beautiful way to change behavior. They sent out a letter to every medical school in the country saying, dear Prof, we're using the data from this very helpful thing called the TrialsTracker made by the data lab at the University of Oxford. And here is your data showing how you are performing on reporting your clinical trials. So this is the template of the thing. This is the number of trials you've got, number of trials that have been complete, number of trials that haven't reported results correctly. The committee will contact you over the summer if the data at that point suggests there is a concern about compliance. Are people happy to receive emails like these? Well, I would hope that they would approach it with a sort of sunny disposition and set about fixing the problem. In the meantime, the AllTrials campaign would be pleased to advise you on the steps necessary. Isn't that nice? You become part of the furniture. This is not mischief. This is helpfulness. This is giving the system the help it needs. It may not be the help it wants, but this is done in all sincerity. So, a friend of mine who's on Medical School Council, which had met the day after these emails went out, said, sent me this WhatsApp message. But, what matters is what happened next and where. Because gradually over time, clinical trials reporting performance improved enormously, in particular amongst industry, not so much amongst universities, with one crucial exception. So this is the proportion of large university trials that have reported their results in each country across Europe, all the countries that have done the most trials. You can see here, this performance is truly abysmal. 40% Austria, 68% Belgium. One country stands alone with outstanding, near perfect performance. And ladies and gentlemen, it is the United Kingdom of Great Britain and Northern Ireland. We are the best country in the whole of Europe at reporting our clinical trials by a country mile. And let me tell you why this matters. People are running around nobly trying to reduce the cost of clinical trials using the data and the platforms and the practical infrastructure of the NHS, and that is a very, very good thing to do. We will probably never be able to compete on cost alone with Brazil, Russia, India, China on cost per patient for randomized trials. But clinical trials are a knowledge business, and part of that is about trust. And trust is driven by showing you're working. And the one thing that we can confidently say, and that we should say more, is that when you see the results from a trial in the UK, you can be confident that you are seeing the full story, not a partial picture. So, next! Is that annoying? Water. In 2021, in the middle of the pandemic, I was asked by Secretary of State for Health and Social Care to do a review on how we can get better, broader, safer use of health data. Now, this was an enormous and frankly traumatizing and entirely unfunded piece of dreadful work that I did with the extraordinary and amazing Jess Morley from our team, who runs our policy team. We spoke to 200 people. We did 8 focus groups. There are 100 written submissions. Nicola Hamilton, the senior civil servant on the review, is also here somewhere. We had 30 summary recommendations, 110,000 words. Actually, one MP grumpily asked a question in Parliament the other day. They said, I've just tried to get the something or other office in Parliament to give me a printed copy of Ben Goldacre's review, and they told me it was too long to print. I feel like I need this on a T-shirt, the Goldacre review. Too long to print. But in essence, we made summary recommendations in 4 areas, and I would say it's fair to say it's been, broadly speaking, well received. I mean, the thing about Secretary of State for Health and Social Care is it's like Doctor Who. They always regenerate very regularly between each season, and they're mostly men. So, announced 200 million quid, kinda, for better data infrastructure. And this, just to take a step back and understand why this matters, this is critical not for UK PLC, not for us, not for researchers who work on the data. This issue of how do we get better, broader, faster, safer use of health data is a critical interest to the entire globe, because the UK has almost unique health data. We have one record for every citizen. In the GP data alone, in particular, which is this extraordinary goldmine, there is one record for every citizen. Every significant event, every diagnosis, every treatment, every prescription, every blood test and its result from primary care is somewhere in there. Going back from the computerization of the paper records, sometimes 70 years. And in this extraordinary, enormous resource, which, by the way, has global importance because we don't just have a large population, we also have an ethnically diverse population, which means results from analyses run in British data are of relevance to people around the world. And in this enormous data set, there are beautiful, critical signals to be discovered about the safety, the effectiveness of treatment, about the logistics of how we improve services, because data is how we find out which drugs work, how we find out which drugs have side effects. Data is how we spot problems in hospitals and surgeons with room to improve. It's how we plan services and optimize the delivery of care. But, and it's a big but, data doesn't do this on its own. Data needs to be checked. It needs to be reshaped and curated. It needs to be housed, managed securely, analyzed by people with skills and domain knowledge, and then communicated and acted on. So, in the review, we made recommendations across 4 domains. I'll talk briefly about 3 and then focus on the last. First up, we said we've got to build a proper NHS analyst profession. There are about 10,000 people in the NHS who self-identify as an NHS analyst. There wasn't even really a proper census or a data structure to discover a more accurate figure. And they are spread across hundreds of different institutions in the glorious kind of pond-like ecosystem of different components of the NHS. There is no profession in the sense of the government economic service, government statistical service, where there is continuing professional development, clear job descriptions at each level, where there are training programs, where there are clear expectations. So we recommended model a proper NHS analyst profession on what's happened in other analytic functions in other parts of government, which I think is, broadly speaking, reasonably well adopted, and I'm not sad if people don't instantly jump. Next! We should enforce modern open working methods. We've talked about transparency with trials. In a moment, I'll talk about the importance of sharing your code. But the point of sharing your code is not for transparency. It is a practical thing. It is about reuse. It's about quality assurance. It's also about how you get collaboration across these huge, multiple, dispersed, arcing chains of collaboration where one person in one organization makes a data set that gets emailed to another person that they then work on in God knows where, and then it gets mixed in with something else. And if you can't see the code, you don't know where the data came from, you don't know what it means. So share your code, which was adopted to an extraordinary degree in Data Saves Lives, the 2022 NHS policy. And then thirdly, data curation, where we made this huge series of very deep technical recommendations, because that is the kind of hidden corner, the most important stuff, but never really talked about or addressed properly. But the critical intervention was to say, please stop disseminating data and instead start using trusted research environments. So what do we mean by this? Well, if you say, where's the NHS data infrastructure? What would somebody say? The answer is, it's this extraordinary tangle of legacy projects, of things that have been built ad hoc as you go. Data is shared by taking name and address off, pushing it round to the next place in the system, to hundreds, thousands, perhaps more of uncountable destinations, each with different arrangements around governance, around curation. Now, this brings an enormous number of problems. First of all, it's a huge duplication of work around curation, around housing the data, around information governance. It also risks creating monopolies, which I can see people who work in electronic health records research are smiling about. Monopolies around access to the electronic health records that we should all be able to use. But it also leads to poor privacy management. And why is that? Well, when we push data to multiple different destinations around the tangle, there are two strategies, two techniques that we use to protect patients' privacy. Because, let's remember, the very same data that we want to use to detect signals that allow us to reduce suffering and death, your electronic health records, also contain some of the most profound secrets for every citizen's life. And we have to keep those secrets. So, two techniques. Number one, pseudonymization. Replace your name and address with a code name. How good is this at protecting patients' privacy? Well, the answer is not very. If you know a little bit about someone, it's pretty straightforward to find out who they are in a large pseudonymized electronic health record dataset. Now, this isn't only true of famous people, but I will give you a famous person example. Tony Blair, you might remember, he had an abnormal heart rhythm reset when he was Prime Minister, once in October 2003, once in September 2004. If you take just that information and a few other basic pieces of information that you very easily know about Tony Blair, and then you go to HES, Hospital Episode Statistics, which until fairly recently NHS Digital would send you out on a DVD. I think the last one I saw was the one on Liam Smith's, literally the shelf in your office. Now, a DVD on a shelf in your office does not transmit an audit trail back to NHS Digital of how that data set has been used. If you take this information and you write a SQL query that looks like this, we've written it for you just to make it easy. If you execute, and you'd be breaking the law, but nobody would know, if you execute this on a machine that contains HES, you will immediately get back, by return of post, Tony Blair's entire electronic health record. It says, find me anybody who matches all of this, and then select star means, give me everything on this person. Nobody would know, critically. Now, this is not to say that epidemiologists are out there behaving badly. This is to say that if we want to prove to patients that we are managing their records safely and securely, we have to do better than say, well, we're mostly making sure that the people we send it to are good. And the problem with making sure that the people you're sending it to are good, and they are, of course, mostly good, but we know that large data sets get misused by a small minority of people, and we have to manage those risks. But the problem with using contracts and evaluating trust of individuals is that it doesn't scale. It is extraordinarily expensive. So information governance, what happens? Well, when we were doing the review, the single story that we got from every single researcher in this space is, can you just eradicate the entire information governance framework of the entirety of the NHS, please? And just send me the data, because, dear God, I've got PhD students who had a nervous breakdown because they came to the end of their funding before they got access to the data. I've got projects that have collapsed and died. This is a menace. Stop it. Don't talk to people. Don't even mention the privacy risks. What are you doing? Oh, my God. So IG, which is necessary if you are insisting on your data infrastructure being sending large volumes of pseudonymized data to multiple uncounted destinations. If you're going to do that, then you've got to have the IG, and if you have the IG, you have the nightmare that that entails. So, our recommendation was, stop disseminating the data out. Instead, put the data in one place, in a trusted research environment. The researchers, the analysts come to the data stays secure, and you know that it has been safe. Now, last thing, are you bored or is this adequate? So, we don't just talk about this stuff, we build it and we built it. Last thing, last tool. OpenSAFELY. In March 2020, it was a scary time, right? In March 2020, we didn't know, in 1939, they didn't know it was the 1939 to 45 war. They just thought, oh dear, Hitler looks like a bit of a problem. In March 2020, we didn't know if we were all going to die of COVID or if our parents were going to die of COVID. And we were in a meeting with TPP about something unrelated, pop-ups. And Chris Bates from TPP, their head of data and analytics, is over there. We talked about pop-ups. And he said at the end, is there anything else? And we said, well, we were thinking COVID's looking pretty bad, and the normal ways of accessing data, you only get a small cut of all the patients in the country. And also it comes really slowly for all the reasons that we know. And so we were thinking maybe we could sort of build an electronic health records research platform inside your data center, because you do, after all, have a room that contains the entire electronic health record of about 40% of the population. Chris Bates began to laugh while saying the word yes repeatedly, and so we did. We went on and we built what is probably the world's largest NHS data research platform. This was a vast collaboration. We extended it to EMIS so that we could cover the entire population. We worked with NHS England as data controller, which I think is critical. I don't want to be the data controller. Morally or practically, that's not right. NHS England should be the data controller. But also working with the Electronic Health Records Research Group of London School of Hygiene and Tropical Medicine, run by Liam Smith, and now all the people like Laurie Tomlinson and Fiz Williamson and everybody else there. And also Len Latterly, University of Bristol, and many, many, many other people. Now, papers. Papers are not the only thing. I will tell you about some of the research we did, but the research is not the important thing. The important thing is the platform. So, the papers. Firstly, our first major paper published in Nature was still the largest study ever done on exactly which types of patients die from COVID-19. Now this, lead all to have Fiz, who's right over there. When we published it, this is frightening stuff, right? Somebody said, God, look at that. This is like TIE fighters in Star Wars coming at you, right? And it is every bit as frightening. This is a huge multiply adjusted model. For anybody who wants to moan about that later, I am available. And you can see here, this is showing the effect of deprivation. This sort of beautiful linear relationship, even after you've corrected for things like obesity and prevalence of diabetes and all of the other diseases. This is the staggering effect of age up here, which is absolutely phenomenal. The sex difference, ethnicity, all of these things. 4,500 citations to date, this paper. Next. So many. What did I put on here? The 58 million records looking at who's being coded with long COVID in primary care. This is, if you've got snotty-nosed children, this is Laurie Tomlinson, who's around somewhere. If you've got snotty-nosed children coming home, they give you diseases, they give you colds, right? So there were two competing hypotheses. Some people were saying, your snotty-nosed primary school-age children, they're going to come home and they're going to give you COVID, and then they're going to kill granny in your multi-generational household. So that was one. On the other hand, people were saying, if you've got primary school-age children, you've had so many colds, so many coronaviruses, maybe you have some kind of residual resistance to all coronaviruses. The answer was, it didn't make much difference either way. That's a good finding. Publish it in the BMJ. Thank you, Cameron Abbasi, who is at the back and editor-in-chief. Next. What else? This is the first and only ever study looking at who is actively declining the COVID vaccine. This is the snotty nose. This is the biggest study ever done, I think, at least with the deepest data, by Rahini from London School of Hygiene on the relationship between ethnicity and different COVID outcomes. This is some of our work on monoclonals and antivirals, led by Laurie, looking at effectiveness, and Bang Zheng, and then Millie Green and Helen Curtis from our team looking at who isn't getting these, looking at inequalities. And we don't just produce the paper, we also produce live dashboards on who's getting this stuff. Do vaccines wane over time? You want to do a big randomized trial. Now, ideally, I would like the entire NHS to be turned into a machine for doing randomized trials minute by minute, because I believe that randomized trials are much better than observational data for answering questions like the effectiveness and safety of treatments and whether they wane over time. But absent a coherent information architecture for the NHS, the best you can do is look at the entire electronic health records of the nation without randomization. And there is this enormous suite of papers from us, London School of Hygiene, University of Bristol, reusing code, reusing tools, producing this avalanche of data on the effectiveness of treatments. So, dozens of completed research paper outputs, more, dare I say it, than other comparable research platforms. And we've done papers on COVID-19 risk, ethnicity and COVID risk, household COVID risk, pharmacoepidemiology, the risks and benefits in COVID, monoclonal antiviral coverage and effectiveness, vaccine coverage, vaccine safety, consequences of COVID infection, long COVID, changes in clinical activity during and after. And it wasn't done by us. It was done partly by us, but also by bazillions of other people working in the platform. But we don't just produce papers. We also produce, again, live, interactive, data-driven tools and services. And we look at changes in clinical activity during the pandemic. For example, this is a beautiful thing, and I felt emotional. This is unusual. When this came off the machine, right? This is looking at, across the entire population of all doctors in the country. On the left, you can see cholesterol tests. And here, at the peak of the pandemic, everybody stopped doing cholesterol tests. Wisely, because they can very much be deferred. On the right here, you can see INR, blood clot tests for people on warfarin. That cannot be deferred by more than a couple of days. And you can see it was not deferred. Across the entire population of tens of thousands of GPs, with no central edict or instruction, the entire community of clinical practitioners sensibly adapted their practice. They deferred what could be deferred in a crisis, and they continued what had to be continued, and I think that's a very beautiful thing. COVID vaccination, 7 days after the first vaccine went into an arm, we had data out showing that there was a massive ethnicity gap, which other people were subsequently able to redo with their own data. But because we've got the full electronic health record of every citizen, we could also say what's vaccine coverage in different fine-grained clinical subgroups, if with learning disabilities falling behind and then catching up. You can ping letters to ministers. We sent letters to CMO, CSA, and all the rest within 10 days, I think, of the first vaccine going in arms, sending them the early forms of graphs like these. So, the data on a biblical scale. Primary care data, there's one row for every clinical event, every diagnosis, every blood test, every prescription, everything. We've got 58 million patients' data accessible, more than 99% of the current living population, all but 59 practices in the country. We've also got key health data sets linked on, like HES and SUS, A&E presentation data. We've got ITU data, we've got COVID tests and vaccinations. We've got a household identifier, which is how we knew that one person lives in a house with a primary school-age kid. We've got research data sets that we've ingested in our Bring Your Own Data service, not just things like the UK Renal Registry variables that people wanted. We've got the COVID infection survey, but we've also got an app where you can design a questionnaire and patients fill it out, and then that gets ingested and magically linked on to their electronic health records for research. But the point is not what we've got and what we shipped in terms of papers. The point is how we did it. So, taking a step back, OpenSAFELY is not a data set. It is a set of tools for safe and efficient use of data, then built on top of large data sets in order to produce a coherent service. Now, there were 4 problems that we set out to fix. I'll focus first on the 2 at the top. Privacy and transparency. For all the reasons that we've already discussed, you cannot allow people unfettered access to the entire electronic health records of the entire population of the country. That is simply unreasonable and untenable. Secondly, people want to know what's happened to their data, quite reasonably. So how do we set about fixing this? Well, let's think about what your data looks like. You go and see a doctor, they say, I think you've got asthma, they enter a SNOMED code for asthma into your record. They say, I'm going to give you an inhaler, they enter a line into your record that says, I'm going to give you an inhaler. What normally happens is, analysts work on a computer that has that data on it, either their own laptop or perhaps a remote desktop into a traditional trusted research environment, and they tinker and play with the data and they write their code and that turns into their graphs and tables. In OpenSAFELY, we didn't think it was okay to do that. First of all, we didn't want to extract the data and send it off elsewhere. So as I said, we built it inside the electronic health records system suppliers' data centers where the data already was. When you do this, you get two amazing things. Firstly, you get data really quickly. Secondly, you get to hang out with people like Dima and Chris Bates from TPP, where they have more knowledge than you could possibly expect about electronic health records because they write the software that generates the electronic health records. Why have electronic health records researchers not historically worked all the time with people who write electronic health records software that collects the data? So we built it there, but we still didn't want the users to be able to tinker with the underlying data. And so we did something better than a remote desktop. We built the OpenSAFELY machine where no researcher gets to tinker with real data. Instead, the OpenSAFELY robot appears. It gives you dummy data, randomly generated fake data. The user interacts with that to write their code. The OpenSAFELY robot takes their code. It runs off into the secure vault, which no researcher ever gets to enter. It runs the code against the real data inside the secret haven automatically, and then it comes back and gives you your code, your tables and your graphs, and off you go and publish your brilliant paper in Nature. Now, the first thing that happens is people say, well, this all sounds very good, but we've heard this sort of thing before. Please trust us. How do we know you work this way? So we put the entirety of our code base, and this is beautiful code. This is very beautiful professional software, all on the internet, all at GitHub, free for review, for security review, for scientific review, for efficient reuse across the community. Next, we publish the code for every individual analysis. We don't ask people to do this. It's part of the design of the platform. You can only execute code against 58 million patients' health records by, first of all, putting it on GitHub in a place where we take it and then we run it. So all of your code has to be accessible before it even starts. But then people said, well, this all sounds good, but we want to know exactly what's happening with the data. And so we said, OK, fine. If you go to jobs.opensafely.org, and any of you can do this, you can see live, as it happens, every single thing that's running against 58 million patients' health records. That I took yesterday. The top one is London School of Hygiene, study on effectiveness of sotrovimab and molnupiravir by Bang Zhang, who I think is around somewhere. And that's a thing by London. This is Bristol. This is looking at SARS after looking at consequences of COVID infection, led by Jonathan Stern's group. And when you click through on each individual job, you get through to more detailed pages. And ultimately, if you keep clicking, you get down to the actual code. Everything, every single line of code that's running against 58 million patients' data. So you go back to the marauding hordes who are saying, no, you can't have our data, the privacy campaigners, the professional bodies, all the people who have historically blocked access to electronic health records at this scale. And what do they say? They say, yeah, all right, that's actually pretty good, thanks. And so, Med Confidential, the most feral of all the privacy campaigners, they put out press releases saying, yeah, this is really good, well done, thanks, please do. Ross Anderson, the great objector to every single big piece of epi that's ever been created, in the 3rd edition of his canonical textbook, Security Engineering by Wiley, there's a whole section on OpenSAFELY going, yeah, this is actually pretty good. Everyone should just do this. That'll be good. Thanks. Citizens Jury, commissioned by the NHS and the National Data Guardian, Nicola Byrne, who's right there, sitting between my dad and Ian Chalmers, founder of the Cochrane collaboration. It's a galaxy of stars tonight. Commissioned Citizens Jury. The Citizens Jury said by a country mile, OpenSAFELY is the most strongly supported of all of the COVID data projects. The only concern that they had was that it might be switched off at the end of COVID. And so that's what allows us to produce papers at this scale in a huge collaboration. But we didn't just want to be secure. Security is not acceptable if it's at the expense of productivity. And so lastly, here are the two additional things we needed to address. Efficiency. Electronic health records data is enormous. Probably more than 100 billion rows of data just for the GP data. This is hard data to work with. You've got to really know what you're doing. You want to be able to turn that into outputs quickly. And also reproducibility. You want the analyses to be open. And so, how do you achieve that? By standardization, automation, service design, and open methods. By having software developers, many of ours are over there, working hand in glove with electronic health records researchers, pooling skills and knowledge creatively to produce tools and services that deliver on all of these. Standardization. All the OpenSAFELY NHS data curation code is standardized, which brings efficiency and legibility and efficient use. We turn the raw data like this into the two-way tables that researchers need that looks like this, with standard functions. We produce interactive online point-and-click tools for generating SNOMED and ICD-10 code lists that do clever things about managing conflicts in the poly hierarchy, and all the stuff which people historically manage with a phone call and an Excel spreadsheet with no audit trail. We do the job properly. We do the hard work to make it simple for everybody else. We produce standard functions like this. When you stop people arbitrarily implementing the same task in 1,000 different ways, instead, if you standardize the code base, then every subsequent user can see and understand it. We make it automated so that you can press one button to re-execute it. And when you do this, when you standardize and automate, it's easy to reuse the code. It's fast. You press one button, kinda, and your tables and graphs re-execute. And you get things like federated analytics for free out of the box. So federated analytics is this great problem which people are they're throwing money at each other to try and fix. And we're going, hello, we've literally been doing this for 2 years now. Half the electronic health records of the nation are in the data center of TPP, half are in EMIS. These are completely different computational environments, completely different data schemata, which I maintain is the plural of data schema. If you were trying to write your own code that would run properly in each environment, it would take you 1,000,000 years to adapt it. You adapt it once in OpenSAFELY. You write your data curation and your data analytics pipeline in the OpenSAFELY language. It gets converted into SQL that will work beautifully in TPP, and then different SQL that will work beautifully in EMIS, and then it runs and it fillets out and you get the answer. Next, we get good efficiency and good throughput by proper service design. We have a beautiful application process run by our Amir Merkar, previously acting chief medical officer at NHS Digital. We employ the stars. They all come to us eventually. It's a 2-page form, generally takes about a week or two to get in. And that's why we have over 150 projects from 22 different organizations, universities, but also NICE, UXA, ONS, and the NHS in using OpenSAFELY to really, truly ship real working outputs. And the last thing we do is we treat it like a service. We understand technical services because the people who work with us, they're people who were previously running the entire data backend of a global retail outfit or running part of a major operating system like Ubuntu. We train them in electronic health records, but they don't forget who they were. They remember that you need to do things like write comprehensive technical documentation, 65,000 words for OpenSAFELY. We have a co-pilot program. Everybody who comes in gets 5 days of person time to make sure they get their outputs. And also, we spy on them benevolently. We know what they're doing, we know what they're trying to do, and where there are changes to the system, we take it and we build them for them. And if they're not being productive and they're not engaging, we take away their credentials because we don't want people who aren't productive in there with access to 58 million patients' data. We build live, interactive, data-driven tools and services on top of it all. And then finally, we make all the code that everybody runs open. Not by choice, but by default, by automatic action of the platform. So it's open for quality checks, open for efficient reuse of each other's code, open for accountability, open because if you tried to p-hack and do the same analysis 1,000 different ways, you could do it, but you would be doing it flamboyantly and in public, and everybody would see you do it, and that would defeat the object. For true technical collaboration, people can extend our code, and lastly, for public proof of delivery, because we are publicly funded, and it's a good for all. So, I'm nearly done. You need a wee. Barriers to delivering the largest electronic health records research platform that I think probably humankind has ever seen. Only one. This is not a diffuse grumble about funders. We have doubled in size once a year. It was funnier to say that when there were 4, 8, 16, and 32 of us. There's now about 40 of us. We've done really well from traditional academic research funders, but we've done it by playing fast and loose. You can fill out a form and get money to do a single academic research paper. People will tell you it's not easy. Of course it's not easy. It shouldn't be easy. And the funding panels, of course, they're capricious and arbitrary and infuriating, but they exist. And this is what has made British science great, is open, competitive, responsive mode funding. Anyone can put up their hand, fill out a form and say, this is the project that I want to do, and you've got a fighting chance. When it comes to data infrastructure, there is nowhere to hand in a form. There is money that comes on the basis of relationships, bespoke special arrangements. Now, we've done okay from those, but we are not the only people who could be building in this space. And I think the single reason why we have not seen beautiful delivery and innovation around better use of health data is that we simply suspended the normal mechanism of funding, which is anybody can apply to do something useful in this space. So, this was built by people, not by magic. It was a beautiful collaboration of all of these wonderful people and all of our many users, and every user contributes code, and it's all wonderful and glorious. And it was also built by a team that fuses skills and knowledge of software development and epidemiology. And I'm terrified I'll forget somebody, so I'm going to tell you who they all are right now. And remember, for every big creative choice we made, if you're impressed by that, there are 1,000 equally creative, equally critical, informed, pivotal choices on every tiny element necessary to build a working system. So our developers, Seb Bacon, our CTO, a hero among human beings, Dave Evans, Peter Inglesby, Ben Butler-Cole, Catherine Stables, our product manager, George Hickman, who's part-time software developer, part-time farmer in Pembrokeshire, Becky Smith, Ian Dillingham, Lucy Bridges, Simon Davies, Seaman Ward, and Tom O'Dwyer and Tom Ward. Our IGN Platforms team, Pete Stokes, who used to run the ONS, TRE, Amir Merkar, Liam Hart, Hilary Winstanley. Our policy and transparency team, Jess Morley, Nick DeVito, Christine Cunningham. Our informatics team, mostly pharmacists, Andrew Brown, Chris Wood, Vicky Speed, and Richie Smoker. And then our Epi and NHS analytics teams, Brian McKenna, Rose Higgins, Caroline Waters, Helen Curtis, Orla McDonald, Alex Walker, Andrea Schaffer, Cole Mandrews, John Massey, Lyndon Hebb, Louis Fisher, Milan Wiedemann, Millie Green, and Will Hume. 2 minutes. Thanks and heroes. First of all, of course, our funders. Welcome, the one organization who has backed us for platforms, specifically for platforms. NIHR, who's funded much of our research. WHO, who did some of our stuff on trials transparency, Laura and John Arnold Foundation, who paid for our TrialsTracker work, the Good Thinking Foundation, Simon Singh, who paid for the continuation of that work, TPP and EMIS, who have given us free access to the data and computational resources during the COVID pandemic to deliver what we did, NHS England, who give us a very large sum of money for the NHS England Primary Care and Medicines Analytics Unit, National Core Studies, UKRI and MRC, who did come through for platform funding during the pandemic, Asthma Lung UK the same, West of England HSN, who gave us 48 grand they found down the back of a sofa to start OpenPrescribing when we first began, and the Moan Westlake Foundation, which has funded a lot of our policy work, and of course, Peter Bennett from the Peter Bennett Foundation, after whom the Bennett Professorship in Evidence-Based Medicine is named. It is a beautiful thing to have somebody support your work, but in particular, it's not just practical support, it's also moral support. When you are giving the system help it needs but doesn't want, it's sometimes uncomfortable, and to be backed makes a world of difference, so thank you very much. Lastly, people, friends, that's Emily Wilson. She used to be the editor of the science bit of The Guardian. Now she's editor-in-chief of New Scientist. Don't people get old? This is Robin Ince, who is a god among men and not actually properly recognized. He took people like me and Simon Singh and others. We were used to giving lectures to people who had chosen to come and see us because they'd read our book or read our column. And he said, why don't you come and do a tight 10 minutes in front of 80 people in a pub in Camden? Why don't you come and do your 10-minute shtick on the TrialsTracker on the stage of the Hammersmith Apollo in front of 4,000 people and then participate in the world's strangest ever Robert Smith impersonation competition. And then who else? Sarah Ballard, my agent, Liam Smith, Prof of Epi, and now head of the London School of Hygiene, a strange experiment in what happens if you put somebody really nice in charge of a public institution. We'll find out in the next 5 years, who knows? Ian Chalmers, founder of the Cochrane Collaboration, My Society, and Tom Steinberg and Francis Irving, from whom I learned so much. Anna Powell-Smith, our first software developer, who now runs a beautiful thing called the Centre for Public Data, which is a truly magnificent outfit, and the original version of the government digital service. My pseudonymized family, whose photographs will not appear here by special request, and I think that's entirely correct, and I will respect their privacy. And then lastly, my mum and dad. It is odd, he does look a lot like me. And not just that, but he's also professor of epidemiology in this town. So we have the same job. And that's my mum on one of her many appearances on Top of the Pops with her 2 top 10 hits as Nusha Fox. I'm sort of off to the right down there with my dad. 1976. You could argue I have fused their careers to become a stage epidemiologist. I still remember where I was, maybe aged about 10, when my dad first explained to me on one particular curve of the Thames how you correct for confounding by doing a stratified analysis using the example of alcohol smoking and throat cancer. And from my mum, I have learnt how to be fearless without being reckless. Right! And also, most importantly, thanks to you, Nothing that we do can be done without your electronic health records. We didn't collect this data. We didn't live those lives. We didn't build the container that collects it. It was the NHS, this extraordinary machine, this embodiment of everything that should be good about civilization, of systems and structures to help each other. And that is something we should all be grateful for and that we should all exploit. So, these are your instructions. The next bit, I will nod to the examiner and the Pro-Vice Chancellor, and then we, excuse me, and then we, oh, you're too kind. Sorry. So, they're not tremendously, I think the sort of origin was practical. You're very kind, thank you very much.
Please rise.